If you could identify and prevent problems in your future child, would you do it? I think most people would say yes. And that's why we are devoting 2 episodes to this important topic, genetics. We're going to talk about so many aspects of genetic screening, genetic testing, and how people carry difficulties and communicate them to future generations. You are going to love this episode. So tune in for part 1 and part 2. From our Building Your Family community, this is the Building Your Family podcast. I'm your host, Lisa Schuman, author, researcher, and reproductive medicine therapist. As the leading destination for support and education for people using reproductive medicine to grow their families, we cut through the noise to provide you with research-based information, effective and actionable strategies, and the support that you need to feel better so you can get into the driver's seat of your life and build the family of your dreams. We look forward to seeing you inside. Welcome to a new episode of the Building Your Family podcast. I think that you should get a pen and paper or your computer or something to write with before you start this episode, because this episode will be so full of helpful information you're not going to believe it. And I will go further to say this episode is for everyone. Why? Because we're going to be talking about genetics, and we're going to talk about the things that you have control over and the things that you don't have control over, and how to make the best decisions for your future family. So I'm going to introduce you to someone who I have a new relationship with, but I'm already very fond of, and her name is Dr. Mili Thakur, and she is triple board certified in obstetrics and gynecology, infertility, medical genetics, and has so many other things that she's got going on. It's unbelievable. She has started her own group called Genome Alley, and she really believes in thinking about how we can protect the health of your future children proactively and how to make it user-friendly, which is really revolutionary and so important. I know that we all get very emotional in this process, but if we can think about some of the things that we have some control over, we can really make huge changes in our future children's lives. So she has worked in this field for several years, and she has a deep passion for individualized evidence-based care for couples with infertility. But she's also an expert, as I said, in medical genetics and well-versed also in fertility preservation, ultrasonography, hysteroscopic surgery, and so many more things. She's going to teach you all the things you need to know about genetics and family building. Welcome, Dr. Thakur. It's so good to see you.
Lisa, thank you for having me. It's great to connect with your audience, and we're going to have a great conversation.
Great. So let's start with the basics, because most of us do not remember our 10th grade biology and are really confused about genetics and its impact on our health and our future. And also, the huge risks that people don't realize, but even just trying to get pregnant as a heterosexual couple at home, the great risks we're taking. I recently had lunch with a friend who works at a fertility clinic, and she works in an administrative role. And she said, well, I'm just going to get some testing because my husband and I want to have a child. And she found out that they're both carriers for cystic fibrosis. And she would have never known that if she hadn't worked in a fertility clinic and just was trying to get pregnant at home. So I think this is valuable information for everyone. So if we can start at the beginning, how can people, just lay people out there who are thinking about this, understand the basics of genetics?
That's a very good place to start. So our body is made up of trillions of cells, and all of our adult cells come from that first cell that we get from the egg and the sperm from our parents. The genetic information inside that first cell, half of it comes from the mother's egg and half of it from the father's sperm. The information is housed inside of chromosomes. These chromosomes have genes written on them. So most everybody that we see around us would have 46 chromosomes total. And there's about 25 to 30,000 genes that are written on these chromosomes. These chromosomes come in 23 pairs, And the reason why there are two in every pair is because one was inherited from the mom and one from the dad. The chromosomes are numbered from 1 to 23 because there are 23 pairs. The first 22 pairs are same in boys and girls, so everybody would have the same genes on those chromosomes. But then the last pair of the chromosome is also called the sex chromosomes that determine the gender. So boys would have an X chromosome inherited from the egg, and then a Y chromosome inherited from the sperm. And girls will have two X chromosomes, one inherited from the egg and one from the sperm. So these chromosomes will have the information that we inherit from our parents. The easy way to understand this for those who don't have a medical background is that, if you were to imagine there being a library inside each cell of the body that the body consults to make different proteins or different things in the body, there would be 46 total books. These books would come into 23 sets of books, and the genes are like chapters written on a book. Because we
Great.
get one book in that set from the egg and one book from the set from the sperm, those books are same in the chapters, but they have differences of what they inherited because those books came from different parents. Now, these chapters are the recipes for making different proteins in the body. Most of the genes that we know either have something to do with making a protein, breaking down something in the body like an enzyme, or regulating the function of another protein. In this chapters, when people say we have a mutation or we are a carrier of a particular condition, that means that there is some sort of a spelling change in one of the words, or either some of the words are missing, some words are extra. And basically, that is what is being passed on. So when an individual passes on their chromosomes, with them the genes, they're passing on one copy of that book. The entire book goes on into the egg or the sperm, and this is happening for every single chromosome that there is to be passed on. So the egg will bring the 23 chromosomes. The sperm will bring the same 23 chromosomes correspondingly. The first cell of the embryo, so embryo, as most of your audience would know, is the first form of the baby. It's the fertilized cell that has potential for growing. And that embryo will get its first 46 copies of the chromosomes, and that is what going to then go into 2 cells and 4 cells, then 8 cells, and so on and so forth, until the embryo becomes a blastocyst. So blastocyst is a day 5, day 6 after fertilization. At that point, the cells have about done so many copies that there is about 100 to 200 cells in there. And then each one of those cells is supposed to have the same copy that the first cell had. This is the stage in a natural pregnancy where the embryo will come down into the uterus, traveling from the tube where it gets fertilized and then attached to the mother's uterine wall. And that's where it will grow. In an IVF setting, if somebody is doing IVF or fertility treatment, that's the stage where an embryo can be frozen and cryopreserved for the future or can be transferred into the uterus. And that's at the stage where we can, do different types of genetic testing on an embryo as well. So in a nutshell, when we say that somebody has a genetic difference about it, there could be differences in the number of total books that they have. So there could be an extra or a missing chromosome that individual inherited. If that individual is a live birth and goes on to be an adult, those kind of abnormalities are called viable aneuploidies. Aneuploidy is the scientific word that we use for an extra or a missing chromosome. And when it's a whole book or whole chromosome that's missing, we call it whole chromosome aneuploidy. The commonest aneuploidy that we know in individuals that we see around us is called Down syndrome. Children who are born with Down syndrome have an extra chromosome 21. So we call it trisomy 21. They actually inherited an extra copy of chromosome 21, either from the egg or the sperm, or sometimes it can happen while the conception is happening. That's one level of the genetic information. The second level is people can have deletions or duplications, which means that there could be an extra or missing pages in some of the books, which because there are missing pages, there could be like missing genes in them, or there could be extra pages where there are duplicated copies of the same genes. The most common microdeletion syndrome is called DiGeorge syndrome or VCFS syndrome. So basically, in that, there is on chromosome 22, one of the books of chromosome 22, there is some pages that go missing, and that causes a whole range of abnormality in an individual. So that's the second level. The third level is that individuals could have mutation in a gene, or what we scientifically call as a variant in a gene. Variant means that the spelling of a word has changed, or some of the words have, or the letters have gone missing, or a letter has switched places. Those kind of abnormalities are called mutations in the lay language, or variant in the scientific language. Common conditions that can lead to these variants, as you probably have heard about, is like Marfan syndrome. There can be changes with cystic fibrosis, sickle cell anemia, spinal muscular atrophy. They're like single gene conditions where there can be a change. And the last level of change could be changes where the all the books are there, all the pages in the books are there, all the words are spelled all right, but then there is changes in how the body reads the information because of bookmarks, which is methylation. So epigenetics is a way of body to decide which cell is going to read which information. So those epigenetic markers can be changed, and there are conditions that are caused because of this, like Packwood-Wiedemann syndrome or Prader-Willi or Angelman syndrome are sometimes disorders which are associated with that. Now, for somebody who's in a family building journey, how do we proactively take decisions is what we do at Genome Ally. And basically what we do is most families will fall into a few different groups. One group is an individual or a couple, who personally doesn't have a health condition that's genetics related, as far as we know, and they don't have any family history that they know about, and they're just proactively seeking answers and making sure that they're doing everything possible for a healthy child. The second group would be somebody who has a family history of a condition. They don't have anything happening to them as yet, or, will never happen to them, but they don't have a personal history, but they do have a family history.
Mm-hmm.
And the third category is a person who has a long family history and also has a personal history going on right now. And the family building process would be different for each one of those groups.
Yes. Imagine your beautiful future. You're snuggling with your child. You feel so connected to them. Your friends and family are so happy, and you have everything that you've ever wanted. I want this for you too, but I want more than that. I want you to feel secure knowing that you've made the best decisions, not just short-term, but long-term for your future family. Wherever you are on your journey, whether you're choosing a donor, choosing a clinic, learning how to talk to your donor-conceived child about their origins, all of these decisions will have wider implications for your future. And I want you to have the right resources so you can feel empowered and confident at this very important time in your life. That's why I'm so excited to introduce you to Building Your Family. It's the only expert-guided platform designed for parents and parents-to-be using reproductive medicine. We provide unique strategies that you won't find anywhere else to make your path to parenthood smoother and more informed. And that's why our approach is about offering practical and actionable steps that you can use right now. Whether you're just starting out or already deep into your process, Building Your Family is here to guide you with expert advice, specialized education, stress reduction strategies, and a community to support you every step of the way. We can't wait to see you inside. So just to highlight something that you said, because I think it's important for our listeners to think about this, in the example that I gave in the beginning and what Dr. Thakur is saying is that you can have difficulties hidden in these books that maybe you don't know about, right? So in that example, neither one of these people knew that this ran in their family. They had no idea. Because, of course, if they had some idea, they would have brought this to their physician and talked about it. But many of us have different things that are hidden in our bodies and our genetics that we don't know about. And so that's why it's so important to do this investigation, because we don't know, as Dr. Thakur is saying, we don't know what is carried from our ancestors, but we also don't know what age, and we'll talk about that in a little while, what age and other factors are doing to our bodies that may also impact on our genetic expression, right?
Yes. So for these mutations, so let's talk about like these mutations in order for your audience to understand the different groups that I talked about, the risk in reproductive family building. For these mutations, there are some mutations and disorders that are called autosomal recessive conditions. Recessive conditions are conditions where the body is able to function normally if one of the chapters, we all have two chapters for each condition or two gene copies of the same name. So for cystic fibrosis, that gene is called CFTR, and cystic fibrosis is an autosomal recessive condition. What autosomal recessive means is that the body is able to function normally if there was a mutation in one of the gene copies. If it's not making the right amount of protein, the body is still functioning okay because the backup copy from the other parent is able to make enough proteins that we don't see a difference. So carriers of individuals with autosomal recessive condition would not have any health history for themselves. They would not have a change, or they wouldn't feel different. And then they would not have a family history of that condition, because they could have a parent who's a carrier of that condition, but their other parent is usually not the carrier of this thing. So that's the first group of conditions called autosomal recessive.
Dr. Thakur, why? I think people might say, well, why is that important? If I have no symptoms and it's not affecting me and I'm not having problems with it and my parents didn't have problems with it, why do I need to find out about that?
So when somebody is on a family building journey, if the egg source and the sperm source both have the mutation in the same gene, then 1 in 4 of their children, or 25% of their conception coming together, would actually inherit the copy of the gene that doesn't work. So in a child, there is a possibility, and that possibility is 1 in 4 combinations, where there would be two non-functioning copies that end up in that child, and that child will then for the first time manifest the disease in that family.
Mm-hmm.
So the likelihood of us being carriers, depends on the ethnic background. So for cystic fibrosis, there is Northern European ancestry, then there is a 1 in 25 chance that an individual is a carrier of that condition. Similarly, another autosomal recessive condition is sickle cell anemia.
Mm-hmm.
In the African American ancestry, or any African ancestry, there would be about 1 in 10 chance of being a carrier for sickle cell disease. Spinal muscular atrophy, again, would have a incidence of about 1 in 35. What these numbers mean, that if you had an ethnic background, particularly for that group, 1 in 35 people randomly carry a change or a mutation in that particular gene for SMA or spinal muscular atrophy. They will not have a family history. They wouldn't even know that they are at risk, but they can pair up with somebody, either with for heterosexual couples with their partner, again, who doesn't have a family history and usually will not have any symptoms, or with the sperm or egg donor if you're using donor. And in that case, you would have 1 in 4 chance of that both mutations coming together, half a chance or 1 in 2 chance out of the 4 combinations of the conception being carriers just like them, and then 1 in 4 chance of being typical. That means both non-mutated copies of the genes were passed to that child.
Mm-hmm.
So overall, when we listen to like a genetic condition, we haven't heard the name usually. We may not put it together most of the time unless we've met somebody with that genetic condition. But these recessive conditions combined together, are very, very prevalent together. So cystic fibrosis is very common as a condition because of the carrier frequency being high. So the chance of like two partners coming together is high. And during family building, we tackle the risk for autosomal recessive conditions through a test called carrier screening. So it's important for a family to know about that kind of risk. And that is the kind of testing that we will recommend to somebody in the first group that I mentioned before, the couple that doesn't have a personal health history, doesn't have a family health history. I strongly believe in doing preconception carrier screening, a test that can look at a panel of genes that are important, that are commonly carried in the population, and being able to figure out that whether you yourself are a carrier of that, and then whether your partner or the egg and sperm source are a carrier of the same condition, and not, go into a pregnancy in a blinded way.
So those are typically the tests that people have when they come to a fertility clinic, and someone will say to them, yes, we have to kind of go through all of these steps as you're part of your fertility workup, and your doctor's recommending that you have carrier screening, and so you kind of have those basic tests done. And so that's, I think, something that's covered probably for a lot of people in a lot of fertility clinics. But then beyond that, we also have to think about these things, as you're mentioning, sickle cell, where people might also know about that. And what do they do then?
Like I said, the second group of individuals who are seeking care for genetics during family building are individuals who have a personal history or a family history. So out of those, there are two groups. There would be one group where they have a family history of a disorder. They don't have a disorder themselves, or don't know that they have the mutation or not, but they have a family history. An example of that would be if there is a family history of a specific type of cancers clustered in a family. That should be a red flag for an individual to look for answers before going into the family building process, for your own health and also for the health of the child. So some of the red flags that can trigger seeking answers could be if there is like multiple family members, either or on one or both sides of the family, with hormone related cancers. Breast and ovarian cancer is quite common. If there is clustering of like rare cancers together in a family is there. If there are younger family members who suffered cancer or had cancer and then it came back, relapse in the family, those individuals should actually, be looking into that more. The other type of history is history of neurological conditions. There are multiple families that we take care of at Genome Ally, where there has been like an untoward health condition for a parent, and they have found out now that their parent has a rare genetic condition like Huntington disease or frontotemporal dementia. There are types of these conditions where a healthy individual later on in life started to manifest like neurological conditions or nerve problems and other things. And now this individual who's now in their 20s or 30s, just about to get married or usually just starting out the family, has found out that their parent who's in their 50s, 60s, or 70s has this genetic condition. And they're trying to see, do I have it? And should, I do anything differently? So this is the second group where there is a family member who's affected. The individual necessarily doesn't know if they are affected or not and what they can pass or not. And we help them figure that risk out. Most of these conditions are passed down. So the cancer-related inherited genes and also neurological conditions, some of these heart-related conditions passed down in an autosomal dominant fashion. Autosomal dominant means that they are on those 22 pair of chromosomes that are same in boys and girls. But these genes don't hide usually in the family. If you have the genetic change, majority of the individuals will manifest it. There are some families where it can still be hidden, but most of the time it will manifest, and then the chance of passing it on to a child is 1 in 2 or 50%.
Wow.
So that individual can just, pass it on. So if an individual has a parent who has, say, Huntington disease, they're at 1 in 2 risk of having the gene, same genetic change that their parent had, being passed on to them to be able to, manifest that disease. And the third group of patients, like I said, are individuals who have a genetic family history of disease, but they also have a personal history already. A very good example of that is autosomal dominant polycystic kidney disease. It's a genetic condition where in the adult life, individuals will start to have renal failure. They will start to have polycystic kidneys. They will start to develop those cysts over their lifetime. Most of the time, you start to pick something's wrong around teenage years. 13,
Wow.
14, 15-year-old can have hypertension. They can pass out. They can have issues with abdominal pain and stuff. So they get picked up. And usually they will have an affected parent. I have some patients who have affected multiple generations of family with autosomal dominant polycystic kidney disease. Now, this individual who's now in their 20s, 30s already knows that they have this condition. And now they're wanting to stop the disease from passing on to the next generation. So in those individuals, we would help them find out what mutation is there, because these conditions are pretty apparent clinically. Doctors sometimes not even look for the mutation. But when we are trying to look for answers for the family and what is the risk of passing it on, we always test them for the mutation, find the familial mutation. Then based on that, we do the risk calculation of is it 1 in 2 risk that you're going to pass this on? And then you choose different options. So going back to our analogy, there's 3 different groups. One group is your average couple, no family history, no personal history. The second group is the one where there is a family history, but no personal history. They are recommended to get tested for the risk that they are at, find out the answer, then we give them the reproductive risk. And the third group is there is a family history, there is a personal history. We already know usually what mutation is there, or we will help them find the mutation and then give them the reproductive risk. So those are the 3 types of families that are approaching fertility doctors for prevention of the disease going to the next generation.
Thank you for joining me today. I hope this was helpful to you. And if you'd like more personalized support, more information, and more education, you can find it in the show notes under the Building Your Family community. We'd love to see you inside. And if you were interested in today's topic, you will really like this video.